Have you ever wondered if that heavy bleeding, that constant bloating, or the ache in your pelvis is just menopause? Most of the time, we shrug it off. We tell ourselves it's hormones. We wait it out. But here's the truth. Sometimes those same symptoms are warning signs. In this episode, we're talking about some of the cancers every woman over 40 should know about and how to tell when it's time to call the doctor. What you'll hear today could help you protect your health and your future. And don't forget to hit the subscribe button to get more real insights. Dr. Nita Lee is an associate professor of obstetrics and gynecology at the University of Chicago and one of the nation's leading experts in gynecologic cancer. But she's also a leader in survivorship care, helping women heal and rebuild their lives after they're diagnosed. She's here to give you clear, practical guidance on how to recognize symptoms, trust your instincts, and know when it's time to call the doctor. Dr. Lee, thank you so much for being here today.
I am so excited to be here to share some information and for using this platform to reach more people.
You know, the work that you do, both in the office and within the community, is so important. And when I found out that September is Gynecologic Cancer Awareness Month, I thought we needed to have this conversation. Can you just walk me through what that means and why women, especially women over 40 and even women in menopause, should be paying attention to this month?
Yeah, I think, obviously GYN cancers can affect people all throughout the year. And every time we pick a month, we just want to give a moment to kind of pause and just be made people aware of both the cancers, the way we can screen or prevent some of them, the way we can kind of do early detection for others and other sort of like risk factors. And so I think it's really just a moment to sort of raise awareness about all of the cancers. There's 5 GYN cancers. So there's ovarian cancer, uterine cancer, cervical cancer, vulvar, and vaginal cancers. And they're all slightly different, but they all are sort of below the belt cancers that many people don't talk about. And so I think we really like our GYN Cancer Awareness Month for being able to spread the word about that information, especially for women who are sort of either later in their reproductive age or after menopause, because this is when we sort of all are like, well, we've had our children. We're not going to really go to our OBGYN anymore. You may have a primary care doctor, but not somebody who's doing pelvic exams. And so this tends to be a very vulnerable time for women. And yet this is the time when most GYN cancers are diagnosed in sort of postmenopausal patients, some in the perimenopause period.
Can we just take a minute and maybe break down those 5 different types of cancers and especially why they would matter so much to women in midlife?
Yeah. I'm going to start with kind of each cancer has its own sort of, take on things. And I'm going to start with uterine or endometrial cancer. That's the most common GYN cancer that we see. And it's an actual cancer that happens most often in postmenopausal women. So women who are usually like 50, 55 or above, the average age is 62. But we're seeing younger and younger women getting it. So the youngest patient I've had was 28 with this cancer. And there are sort of known risk factors. And we also know that in the United States and globally, uterine cancer, endometrial cancer is rising every year, unlike us hearing about other cancers decreasing. The one issue with that is that there is no screening test for endometrial or uterine cancer. Endometrial is sort of a type of uterine cancer, which is from the endometrial lining. So if you think about the uterus like a pear, the lining is where we have a cycle every month. That lining has glands in it, and that's where most of the uterine cancers arise. Because there's no screening test, women can have pap smears, but that doesn't actually test for uterine cancer. So most women with uterine or endometrial cancer will likely have had normal pap smears. So this is where it's really important to rely on symptoms and notifying your physicians and thinking about getting ultrasound and, more importantly, an endometrial biopsy, because of the fact that we can't really rely on like an easy other test. And that's one thing that we really want to emphasize, that bleeding after menopause is not normal, needs to be looked up. Bleeding in the perimenopause that changes in cycle may be okay, but I think really talking to somebody to make an assessment of whether or not you need a biopsy is really important, because sometimes we'll see women who've been bleeding for a really long time before they even get their diagnosis.
You said there are 5 types altogether that you focus. Okay.
So ovarian cancer currently is one of the ones that's less common. So for uterine cancer, there's close to 70,000 cases per year. In ovarian cancer, there's closer to 22 to 24,000 cases per year, but it is actually I wouldn't say more serious. It is a cancer where it can be even more significant, because the majority of women who are diagnosed with ovarian cancer, so 70 to 80% of them, will be diagnosed in later stages, stage 3 or stage 4, meaning that it's diagnosed beyond it being in the pelvis and kind of in the abdominal cavity. Also, the problem, we don't have screening for ovarian cancer. And so that's an area importantly that we need research in. But we also know that there are some symptom triggers, such as fullness, changes in bowel or bladder function, decrease in appetite. Now, these vague symptoms are things that we could all experience, but it's really, if a symptom is like new and different, persistent, and lasts for a couple of weeks, it's different than your normal diet bloating if you eat something, or, if you've done something differently. But something that's new and different for you really needs a workup. And this is where I really think it's important for women in the perimenopause and postmenopause to really advocate for themselves, because a lot of women that I see will have gotten a little bit of a different type of workup or not really listened to. And so that issue of people saying, oh, maybe it's GERD and try some Pepcid for a couple of months, or maybe you need a colonoscopy, and they get a colonoscopy. And suddenly somebody's coming 6 months later when they have, a lot of like disseminated disease, where perhaps even if it would have been stage 3, it would have been a very different stage 3 if I had seen it 6 months before. So there's just these nuances in that diagnosis. Genetic testing for ovarian cancer is really important. So the BRCA genes and a group of genes that are related to hereditary breast and ovarian cancer are really important. So anybody who has that diagnosis should get tested, because then their children, siblings, male, female, could potentially benefit from sort of a cascade approach of testing, and risk reduction surgery and different things like birth control pills are actually preventive against ovarian cancer. So there's sort of different ways of that we try to approach each cancer in terms of like risk reduction and diagnosis. The other cancers that we think about for GYN cancer are cervical cancer, which again is about 12 or 13,000 cases in the United States. Compared to the world, this is much better, but this is an almost entirely preventable cancer. And this year I've been seeing like at least 1 or 2 women a week rather, presenting in my office with this cancer. And many women have not been as up to date with pap smears, or maybe they had pap smear but didn't understand that it was abnormal. Many women don't have access to care, but even women who have insurance and have access to care, we just don't prioritize it, right? And so we get these missed opportunities for cervical cancer, which is really important. Cervical cancer is also preventable by the HPV vaccine, which is given generally to teenagers, like starting age 9 to 12 is the ideal time to get it. You can get it up until age 45, but we're also missing that. So countries that have gotten HPV and said, hey, great, you have a cancer vaccine, we're going to give it to all of our 12-year-olds, like the UK, they've seen a dramatic drop in cervical cancer numbers in young patients. And we just haven't seen that yet in the United States. So I think cervical cancer, that's the other one that's really the most preventable. So sometimes that seems like even worse, because we have all these missed times that we could catch it. And then vaginal and vulvar cancers are rare cancers, generally happening in older women, not always, but these are times where there's external symptoms, bleeding, sort of a rash, itchiness, all the symptoms that many people are really embarrassed to talk to their primary care about, or even bring up to their gynecologist. And so a lot of time this gets also treated without visualization, without an exam, without a biopsy. And then suddenly somebody is finally like, wow, I'm bleeding now. And then we see that they have this very large lesion, right? So those types of like really important symptoms and symptom recognition for when to seek care are really sort of some themes in GYN cancer.
Yeah, I was going to ask you about what are some of the symptoms that we shouldn't or can't ignore?
Yeah, so I'll start from the bottom up, I guess, in some ways, but like the vulvar skin on the outside, it is common to have some vaginal dryness sometimes, or itching, but if you have a persistent area that's really bothering you, and you've either tried something, it's important for somebody to do an exam there to make sure that they don't need to take a sample, because there's some precancerous inflammatory conditions. Sometimes it's related to HPV, sometimes it's not related to HPV. these treatments, these conditions can sometimes be treated so that you don't get into a cancer situation. But the most important thing is actually getting the area just looked at to see if anybody thinks that they should do a biopsy. For vaginal cancers, it's really important to think about, vaginal symptoms such as abnormal vaginal discharge, vaginal bleeding after menopause or between periods. The same with cervical cancer. With cervical cancer, we really actually want to find times when people don't have any symptoms and we just find an abnormal pap and we do a workup and we find a very small, easily treatable cancer. But if people are having irregular vaginal bleeding or discharge, it's really important to see the gynecologist. I've actually had some patients say, well, I was told I couldn't go because I was bleeding and I couldn't get on my pap smear because I was bleeding. And I was like, well, but somebody still needs to do an exam. And so really emphasizing from my perspective, having patients and women really sort of like, sort of take that as an empowerment tool to say, no, you really have to request that, even though it's uncomfortable.
Do you find that as women age that we avoid going to the doctor more and more? Like, I don't think I need to see a gynecologist because I'm done having babies, but it's probably when you need to see them the most as you get older.
I totally agree. I mean, I think there's not like one hard, fast rule, right? You have to think about what are the other medical conditions, what are the other things happening. But I don't think it's a bad idea to have someone do a gynecologic exam way after the age of menopause just to check the ovaries. Once in a while, I'll get somebody who gets referred to me for an ovarian mass that was like, hey, I was just going for my annual exam and my doctor felt something and did an ultrasound, right? It's also just a time to check in about those symptoms during our busy schedule, right? So you may be like, okay, I'm going to go see my gynecologist. And then the gynecologist asks you, hey, have you had any irregular bleeding or spotting? And then you're actually going to pause and be like, actually, I did a couple of times. And that could trigger an appropriate workup, as opposed to if no one ever asks you those questions, you may either discount it or sort of assume that it'll be fine because it was minor. And nobody really wants to kind of think about a symptom that we have internally being something bad, right? We're really good at like dismissing it or just kind of explaining it away. Oftentimes women are talking to other women, like we talk to our sisters or our friends or, to be like, oh yeah, that happened to me too when I was perimenopausal. I'm sure that's what it is. And so it's easy to grab on to the like best, easiest explanation. But the problem is a lot of women then don't get the workup. So we kind of miss the opportunity to catch things early. That's very, very true of postmenopausal vaginal bleeding. So any postmenopausal vaginal bleeding really has to be like looked up in terms of making sure people are up to date with their pap smears, but then also making sure that they don't have something that would require a workup for endometrial cancer.
You're so right, though, about women talking to each other. And while that's a good thing, sometimes
it's a great thing. It's a great thing.
Sometimes you do get those, I wouldn't say that they're excuses, but it's like, oh, my sister had the same thing and it was fine. And she was just in menopause or it was just hormones. Do you feel we need to stop explaining things away in such simple terms?
No, we don't want to like medicalize everything about menopause. And I think that's really important because there are some natural things. It's just that I think it's good to have a connection to a provider who can kind of like help you make that decision. And then if there are persistent patterns, like if there's like red bleeding after menopause, like that really needs a biopsy, like without fail, right? That shouldn't be something that happens. Like, so some people will kind of hear things like, oh, I was in menopause. I went to menopause at 54. I stopped having my periods at 52 or whatever the date, and then, oh, at 56, I just had bleeding again. I just figured my period came back. It doesn't come back. It's not your period coming back, right? So those types of myths are really important to kind of break up a little bit. And I do think it's really important to have like other women telling women that, if that makes sense. So we work with a lot of our patients who are GYN cancer survivors who've had that experience, and they're really very motivated to say, you know what, I had never even heard of this cancer before. I didn't even know that this could have a cancer in it. And so now I tell all my friends, like, if you have the symptom, go get it checked out. And so that important exchange around the social connections we have, I think is really important, which is why I love podcasts like this or, opportunities, because I think different people hear things differently. And it's not to say that everything has to be so regimented. You may not go to your doctor every single year, right? But you should know about, when your last time was. All those things are really important.
You mentioned
easier said than done.
Oh, sure. You mentioned in the beginning that there aren't screenings for certain cancers. Is that because it's too hard to screen for that, or is there another reason?
Yeah. Yeah. So, for ovarian cancer, there have been a lot of really big, giant studies with hundreds of thousands of women, both in the United States and in the UK, looking at the role of ultrasound, a blood test called CA-125. And none of those studies that were done on a global scale of healthy individuals without high risk features, such as a family history, really didn't find early cancers in between the screening. I mean, during the screening, some of the cancers that were found in that cohort of women, which is randomly found in between. And so there wasn't enough to kind of like warrant doing that. And the reasoning behind it is that, like, if you get an ultrasound and it's like kind of positive, there's like a lot of gradations, and then you have to commit to general surgery, right? Not general surgery, general anesthesia to do. There's not a way to like easily test the ovary without taking it out. And so that commitment of like the number of people you would have to like actually put through surgery, those potential risks, that becomes like a public health decision that, like, public health wise, it just doesn't make sense, right? Because the tests aren't good enough. There are a lot of people who are looking at kind of new technology in terms of like how could the pap smear technology be reinterpreted and reutilized. There's some great work being done at the Mayo Clinic on looking at like how paps could be like sort of reconfigured to screen for proteins or potential markers for endometrial cancer or ovarian cancer. So there's a lot of different things that can be happening. We're looking at a partnership with there that's looking at like a tampon type test that can be looking, to see what other things and chemicals could be secreted that could help us screen for those tests. But none of it is like completely FDA available other than cervical cancer screening. And so that's why we sort of hone in on like cervical cancer, very preventable. Having your pap smear and HPV test done is really the best way to do it.
What are some of the questions that you wish women would ask their doctors? Because I know when you go into the office as a doctor, you have a lot of questions for us, but maybe we should be asking questions also.
Yeah, no, I think that's a great question. I mean, I always feel like it's good just to kind of like make sure that people feel comfortable like asking about like any changes that they've experienced. Like, so asking or saying like, hey, is this normal that I'm having this dryness or this spotting or whatever it is? Because then we can kind of better interpret it. I think knowing also like, are there any other risk factors that I would have? Like if I ask my doctor, hey, look at my profile. Are there other things that you think I'm at risk for, right? That I should be thinking about? So that's an opportunity to really think about like family history. So family history of young onset of breast, prostate, colon, uterine cancers, any of those things can kind of be maybe a little bit of a like, like raise a little alarm to say, hey, you know what, this person may be at a higher risk. Maybe they need to be referred to genetic testing because they told me something about a family history that I didn't know. Like I had a patient whose daughter got diagnosed with breast cancer at a young age, and it was through her daughter that she found out that she had a genetic testing, like she had a BRCA mutation. So it was really interesting. Ended up seeing her for a risk reduction surgery, but she didn't really found that out until she, went to her gynecologist, and she was talking to her gynecologist more socially and told her, oh, my, 35-year-old daughter got diagnosed with breast cancer. So sort of asking about, family history, that's an important thing to kind of think about. Other questions are sort of, a lot of the questions tend to be around gynecological health or sort of like related to sexual function. So not being afraid of like talking about that and kind of bringing that up. Also just sort of like getting to know your body a little bit in terms of like what types of like gut health works for you, what makes you feel better, what makes you feel worse, getting to know yourself a little bit more, especially as you're reaching into the 50s and getting into menopause or perimenopause or postmenopausal. I think that becomes a little bit even more important, I think, because there are more changes that happen. And you don't want to think that everything's cancer because it's not by any means, but you want to just be like smart about some of the symptoms.
I think we're getting better communicating with future generations because I know, like my mom, she never wanted to talk about any of these things.
Yeah.
Um,
Yes.
and so it is important, though, to know your family history and to make sure that everybody in the family is aware of what's going on.
Yes. Yes. Now, only 20% or so of people will have a genetic predisposition to developing ovarian cancer, for example, even less for uterine cancer. But it is important to know that history because those are people where in the family we can make a really big difference in cancer prevention.
Sometimes I feel, going to the doctor can be a little intimidating. I mean, you're a very
For
nice person,
sure.
but sitting in your office, being on the other side of that, it can sometimes be scary. How do you think we can better advocate for ourselves when you know your body and you're like, something isn't right here without feeling
Well,
dismissed?
I think that's a really excellent question and point. I think one thing is like definitely bringing, I often tell people make sure you bring somebody with you. Like they don't have to be there for the whole exam or if there's something more private, but like having like another pair of ears and somebody else who can kind of like back you up on your team can really help to kind of like emphasize that. I do think like having some of your questions written down are important in terms of just being sure. Because I think when we're in the doctor's office, we like, it's like, even for me, you get flustered. You're like, oh, like I forgot to ask this question. And so having that kind of organized in your thought process of like what you're getting at or what you're worried about is important. And quite honestly, like if somebody's dismissing your symptom, to be like, I'm actually really concerned about this. And I really need to be able to make sure there's other testing or there's somebody, and I think just pushing back a little bit, I think is really fair. And quite honestly, if like you're really getting like not good pushback, I think getting somebody else to see you, quite
Mm.
honestly, which is really scary for patients to think like, oh, I have to go see another doctor. But if there's something in your gut that's telling you like this just doesn't feel right and I'm just getting blown off or I'm just not really getting the right answer, or fast enough, I think it's very, very reasonable to kind of push a little bit further.
The other thing too, though, is that we have a primary care doctor and maybe we have a
Yes.
gynecologist and maybe you have a specialist. It's hard to know how to coordinate all of that care.
No, that's very true. I mean, I think it's, we definitely think that we should be thinking about like how to better coordinate that care through our electronic medical records and the symptoms and different things like that. But I do think it is kind of making sure like all your doctors know whichever, whoever it is, or bringing in records if you're in multiple different health systems, like all those things can be helpful. If there's like a specific like procedure or event that has to happen, making sure everybody's on the same page, those kinds of things are important. But it is true because especially as we age, we have like a much more complex like medical team, if that makes sense. And so I agree that can be really challenging.
When I was doing a little investigative work on you, I found that you use this phrase survivorship care. Can you talk about that a little
Yeah.
bit? Because I think it's more
Yeah,
than
this
just
is
recovery.
Yeah, no, I mean, survivorship care is really, really important. It's a very patient-centered approach that was really created by groups of patients who lived and experienced a cancer diagnosis and were like, hey, yes, we survived this, but we have potentially a lot of like treatment side effects. We have some psychosocial side effects. Survivorship care really begins at the diagnosis of a cancer. So anybody who's diagnosed with a cancer. Now, some people do not like the term survivorship and feel like if they're on active treatment, they'd rather use a term like thriver or just somebody with cancer, right? They don't necessarily have to adopt it. I think it comes about because it provides a framework for how to understand taking care of patients who get a cancer diagnosis in their life. Like, we don't want them to be defined by that cancer diagnosis. But when you think about survivorship care, we think about sort of like the physical, sort of like effects for treatment that can be both short term and long term on different organ systems, sexual function, mental health during and after a diagnosis. This is kind of considered sort of almost like a traumatic event. So there's a lot of like, issues around anxiety or depression or fear of recurrence. There's a lot of social concerns regarding survivorship, meaning some people have financial concerns because they lose their job or they have to go on disability or the treatments are so hard for them that it changes what their work looks like. Or, so there's a lot of like elements of things. We think about the physical, the psychosocial, the mental health side of things. We also think about making sure we're doing like good surveillance for the cancer coming back and also making sure we're also like doing good screening to make sure people don't develop another cancer, right? So if I'm seeing somebody for endometrial cancer, I think it's also my job to make sure that, hey, are you up to date with your mammogram? Have you gotten colon cancer? Like, I don't want to be like patting myself on the back because I did a great job with your uterine cancer, but you get all these other issues, right? And so I think survivorship care encompasses that element of things with the idea that we really want to keep the patient needs in the center and knowing that those needs are very different after a cancer diagnosis. And so that whole big term, it can be very, very broad. Some people use it kind of as more of like an education platform. Some people really use it to kind of provide different levels of support and awareness about the disease that they may have experienced. And then I think as a clinician, we tend to build programs around survivorship. So at UFC, we have a lot of like different elements of survivorship. So we have a oncology program. We have a sexual function after cancer program. We have an acupuncturist. You have people who are doing nutrition and PT that are very cancer specific. And so making sure that that like rubric is like, at least like not every box has to be checked for everyone, but that we can kind of make sure that people understand that we don't want to just like be thinking about their cure in a way that's outside of that. Because I think a lot of times it really comes from the time where people were like, you should just be happy that you're alive. Like, right. Like we cured you. Like, why are you complaining? Right. Like that's not a really helpful like a way to approach things.
I know that there's a lot of fear around the word cancer, but it
Yes.
sounds as if there's also a lot of progress being made. What gives you the most hope for women right now?
I think there's really good progress on a lot of different fronts. And so I think our therapeutics and our clinical trials of like new drugs and new classes of drugs, if that makes sense, are really accelerating like very quickly, right? This is why we think actually science investment is so important, right? So we're really worried about some of these cuts that are happening because we're like going to see these drop-offs, right? We may not see those changes yet, but just the amount of new drugs that have been available, for example, for uterine cancer in the last 5 to 10 years have been life-changing. I know I have patients who would not be here today if we didn't have these drugs, right? And the rapidity, like how rapidly something can be in a clinical trial and get FDA approval because it's been working very well, has also really shifted how we think about clinical trials. So clinical trials are not a last resort. They're not something that I use when I can't think of anything else. They're actually like the biology behind it is actually moving these trials into first line, second line, because then we're getting these drugs into people sooner. And then like 2 years later, they're already FDA approved and are standard of care. So this idea that like there's a more spectrum of drugs that are coming out there. And really importantly, those drugs are really looking also at like quality of life and toxicities much more than they used to, quite honestly, like much more than people would look at that like 20, 30 years ago, right? So this is really like, requirements that quality of life is measured. We're often thinking about how well did the person tolerate this treatment? Like, were they able to function? Were they able to work, do the things that they want to do, travel sometimes, or go make major life events like weddings and baby showers and things. And so that gives me a lot of hope. I think there's more engagement of patients who want to kind of be in research. And that's a particular interest of mine, of like sharing their sort of like personal lived experience with researchers so that they start to ask those questions about how can they make the treatments better, and what are the questions that they can do to make things more humanized during the process. So sometimes we look at things like, myself and one of my colleagues who is with me at University of Chicago, we're like looking at something called time toxicity, where we're looking at like what's the like effect of like how much time when you're a cancer patient that you have to spend away from home for your treatments, right? So there's a lot more like interest in like trying to make it patient centered. So cancer, very scary. Obviously, I totally agree, but I think there's more people who are living longer with cancer diagnoses, and there's a lot more treatments out there. So I'm hopeful for that. And people are finally like, we're all trying to understand now, like how our diet, our exercise, our physical activity, like it's all connected, right? So I think there's more awareness of that, which I think is important. There's better vaccine technology, like the HPV vaccine is like amazing, right? The fact that we have that. So I think there's hope in the like scientific field and that patients are really engaged. And so I think those two things are really important.
I think I've heard from other women in my group that they felt that the vaccine, the HPV vaccine, everybody was a little, I don't know what you would say, like they were afraid when it first came out. Like, should
Yeah.
we be giving that to our
Right,
children?
right.
And
Yeah, yeah. No, I think this was really controversial when it first came out because of the way that it was like
Mhm.
shared, right? So instead of it being marketed as a cancer vaccine, it was marketed as like, well, there's a sex vaccine and maybe you want your kid to have it or maybe not. I don't care. Do it if you want. It was never like you should do this because we're going to prevent a type of cancer. So I think now that it is so old and there have been so many billions of vaccines across the world, and we have countries that actually adopted a vaccination program that have seen these like dramatic drops off in cervical cancer. I just think it's a shame to not use the technology, right? So some people, the myths around HPV vaccine, that could be a whole podcast, but I think, some of the myths were like, oh, it's going to cause infertility. Actually, girls who are not vaccinated, those are the ones I see when they're in their 20s and I have to take off a small piece of their cervix every couple of years because they have HPV. And those are the ones who may have fertility issues or pregnancy complications, right? So it's not the people who are vaccinated, right? So there's those elements. Obviously everyone's going to be able to choose what they want to do, but I think the worst is when I'm seeing, young women who are in their 20s and 30s get cervical cancer and they were not vaccinated. They were not given the choice. They were not told about it. Families tried to do their best to decide what to do or not do, but now that we have the data, I think it's really time to use it, So I feel pretty strongly about this because I see way too many young women dying of cervical cancer every week, right? It's just anything that we can do that has been shown to be, safe and effective. But again, like I said, just the mention of vaccine creates controversy, but I think we can use other countries as our guide to say, hey, you know what, they actually, started to eliminate some things. And we have a good track record now of how that went. But again, everyone's going to make their own decisions. But when you're faced with what we see every day, or many of our survivors who are out there advocating for HPV vaccine so that a woman can avoid loss of fertility, pain, sexual dysfunction, a lot of these long-term things, I'm just really motivated to think of that as one of the things that we could be doing. But it was scary.
Right.
And I think it was scary because I think it just wasn't framed correctly.
I would agree, because when it first came out, it had you questioning what the point was.
Right. Yeah. And a lot of it has to do with stigma, right? So if somebody said there's a breast cancer vaccine, people would be lined up around the block.
Yeah.
But because it's HPV, there's this thought oh, that only happens to people who are loose and have lots of sex partners. And I'm like, nope, you can have one sex partner and that's it. You could be completely monogamous, married for 30 years. You can still get HPV if you're not up to date, right? And you haven't been vaccinated. And so I think that stigma of HPV related cancers, which is that cervical cancer, really affected how the vaccine was, both advised by pediatricians, how we talked about it, how the marketing was done. I think there was a slew of stuff that I think we could have done better. But it's, I think the important part is the stigma against cervical cancer is really still high. And so people feel oh, I don't need to get that. I'm not that kind of person, right? And that is just not true. I see all sorts of people and all sorts of experiences. And I think that's just really the hardest part of all of the cancers are difficult. Some are more preventable than others, and cervical cancer happens to be the most preventable we have. So uterine cancer, there's a portion of uterine cancers that are actually related to kind of our weight, our gut health, probably our nutritional, diet quality, carrying extra weight. So about 80% of uterine cancers are related and are what's called obesity driven, just like postmenopausal breast cancer. So that's something that we never want to stigmatize somebody to say, oh, you have all this extra weight, you cause your cancer. That's not true. We don't know why, right? So somebody of the same BMI, same weight, they're twin. Why did one person get it and the other person didn't? Those are factors we don't know, right? Environment, gene interactions, other random things that we don't know. But there is a trend towards that. That's been long standing. And so kind of keeping better health, not only do we feel better as we go into menopause where we're actually becoming more physically active, you are actually doing cancer prevention for many things, right? And it's not a number. That's why I always tell people, it's not oh, you have to reach this BMI. It's actually just are you physically active or not physically active, right? So those are some things that we think of for the endometrial side of things.
And you're not the only one who's ever told me, or the doctor that I've ever talked to, who stresses the importance of physical activity.
Yeah, even if you don't lose weight, if you build strength and you're just more physically active, there have been some studies that showed just regardless of BMI, your physical activity really had people who are less physically active, more physically active. That's where the cancer risk came too, right? So all of these things are more more related than we think. And I think people think, oh, well, that means I have to walk, 5 miles or I have to do a 5K or something. You really don't. It's really small volume exercises can do the trick.
But get out of the chair or off the sofa.
Yes,
Just do
yes,
something.
anything. I mean, and it's true. It's so much easier said than done. And I feel like the last several years, I've been like, I have to practice what I preach and make that a priority. And it's always a challenge.
Well, I'm glad to hear you say that because sometimes, you have to walk the walk or talk the talk,
It's
whatever.
so impossible. And definitely there's not a win every day, but I think when there is a win, we should all celebrate.
Well, since September is Gynecologic Cancer
Yeah.
Awareness Month, how do we want to spread the message? What's the best way to do that?
I mean, so I will say one of the resources that I love, and there's a lot of great resources online, and I'm sure there are many of them, but the Foundation for Women's Cancer is is a nonprofit that's related to our Society for GYN Oncology, and that's a really important place that has a lot of great patient resources, and I'll send those to you via email so you can share them to your colleagues as well, because there's a lot of really good information about each cancer. There's some things that are like really short one-pagers. There's more in-depth information as well as some videos. So I think it's important to kind of think about sort of like general information sharing and where we get our resources, right? That's an important thing. I think telling women to like listen to their bodies, right? So the major symptoms that I would think about is like irregular bleeding, gotta go to gynae. Keeping up with your pap smears. Other symptoms include changes in your bowel and bladder function, your urinary function, major changes in weight or appetite, those kinds of things. These are all, pain that doesn't seem like it makes sense and it's new and continuing to increase. All of those things really warrant your just kind of valuing yourself and saying, no, I'm going to prioritize my health. I'm not going to take care of everybody under the sun, which is what we all do, right? And I'm going to go to the doctor and ask them and like force myself to ask these questions that might be a little scary. And then also when you hear people talking about symptoms or you notice symptoms, sometimes I'll say, like I will, have patients come in and this person will come with their sister and they'll be like, I noticed that, but I never said anything because I didn't want her to think I was like saying she looked weird in this dress or something, but like it's kind of not being afraid to kind of like look out for your friends and family. If people mention things, just bringing up the idea of like, hey, I happened to hear this random podcast about uterine cancer. Who knew that this was even a cancer, right? Like it just brings that idea up and really not being afraid to kind of advocate for yourself at the physician's office. And I love all of the doctors that I work with, whether they're primary care, general OBGYN, they in some ways have a much harder job than I do because they have to see like the whole world and the whole world is not going to have cancer and they have to kind of decide like, how do you triage this and like who gets a test and who doesn't and how do you, so it's hard for people to be in that role. And so I think that's why we do, provider education as well, but we really think about the frequency and the intensity of these symptoms. If they're new, different, like they need workup, right? So they need a good pelvic exam, possibly an ultrasound or a CAT scan. I don't think it's too much to say if those symptoms occur to really push forward with it, even if it may seem a little scary. And even though it's not, most likely it may not be that, right? It may be something entirely different. So.
Yes, and it's better to be safe, but also as our role as a patient, we need to be honest when we go to the doctor.
Yeah,
And
that's true too. Yeah, that's true too. Yeah. And I think that a lot of the things with gynecological cancer awareness is that we just compartmentalize. Like even when you go to see your primary care doctor, you don't talk about GYN issues. Like it just doesn't come up because the primary care doctor doesn't bring it up. I have a colleague who's actually looking at this like way of like asking like a postmenopausal checklist for primary care doctors to be like, hey, just ask if they've had bleeding, right? Just ask if somebody's had these symptoms because that in and of itself could trigger somebody to get an ultrasound or to get a biopsy. So kind of being aware of GYN's cancers as a thing that we can screen for. I always tell people 20% of patients who have cervical cancer are over the age of 65. Right. And that's because they've not kept up with their pap smears in their 50s and 60s. And 65 is the age that people say, oh, you don't have to have pap smear anymore. But nobody reads the fine print of that guideline that says if you've had 10 to 20 years of normal paps, right? So people are like, oh, great, I'm 65. I never have to have that stupid speculum exam again, right? But I still see older women coming with those issues. And so I think that, like you said, being open and honest about symptoms and keeping up with the screening, family history, again, really
Mhm.
important to see what we can do for risk reduction. So many things. But I think just talking about it and just being aware that like GYN cancer is a thing and that those symptoms are often underreported or underrecognized and maybe dismissed. I never want to say that it's anybody purposely dismissing. I just think there's so many things that cloud that picture that it's important for patients to advocate for themselves.
Right. Before we leave here today, I just wanted to say thank you so much for taking the time and just raising awareness about this, because until I met you, I really didn't realize that there was a category of this type of cancer
Yeah.
that affects women.
Well, I am so thankful for being invited to do this. I'm so glad that we connected randomly, but at the same time, I think it's really important to kind of get these messages out in different forums that people are hearing things differently. And so again, it's not that we want to say that everything's going to be cancer because it won't be, but I
Mhm.
think it's an important part of just kind of like staying healthy as a woman, right? Knowing that that's out there so that you know what your own risks are. So I really appreciate it. And I will send you some list of those resources. And I think people advocating for themselves or their loved ones, I think is really the key.
Is there a way to follow along with the work that you're doing or to connect with you in any
Yes,
way?
yes, definitely. I will. You should. I would think we actually have a website for our community outreach and engagement. We also have through Foundation for Women's Cancer. I will probably have to send that to you separately because, of
Mhm.
course, right now I cannot remember what any of those things are. But I think that those are different ways. And I'll also put into, we actually have some upcoming webinars that are coming up that are on GYN cancer, including a GYN Cancer 101, an update in GYN cancer research, as well as a survivorship panel. So I will send you that flyer. So feel free to distribute it for anybody who's interested. It's open to the public. And we would love to share more information.
Perfect. I will do that. I'll make sure to put it in the description when I put it up on YouTube. And
Yeah,
again,
that'd be great.
thank you so much for being here today. Thank you for joining us on Real Insights. If you want to hear more about how other women recognize the warning signs, order your copy of Empart, Real Stories, Real Wisdom, Real Menopause on Amazon today. Don't forget to join the conversation at joinempart.com. Until next time, remember that menopause is a journey, but you're not alone.